Hi, I'm Ron Zimmett. I'm here on behalf of Negley Associates in our continuing series of video risk management tips for community mental health centers. Today our topic is suicide assessment scales. In one of our previous risk management videos, I discussed actuarial instruments used to assess the risk of violence in mental health patients. These are typically instruments which have been the subject of a great deal of study and validation. But what about instruments to assess the risk of suicide? Over the years, I have seen a variety of different kinds of instruments being used by mental health centers. Many of these instruments result in some type of score indicating a level of risk. The risk level can be expressed by a number score or such terms as high or low. Some of the instruments are designed by the staff of the mental health center and have not been validated by research or use. Some are more formal and have been obtained from researchers. Well, using these kinds of instruments for assessing suicide risk is problematic because many of the leading experts in the field, including the American Psychiatric Association in a clinical practice guideline, have concluded that the current state of the art does not justify using scored instruments, at least as a standalone approach. Here's what the guideline says. A wide variety of self-report and clinician-administered scales are available that measure various aspects of suicidal thoughts and behaviors as well as symptoms associated with suicide. These scales are reliable and have adequate concurrent validity, and they may have application as research tools. However, their usefulness and generalizability in clinical practice are questionable. Most of the scales have been tested in non-representative samples composed of college students or psychiatric patients and have not been adequately tested in important subpopulations of patients, such as elderly patients, minority group patients, and patients in common clinical settings, including emergency departments or primary care practices. Few of these scales have been tested in prospective studies, and those that have been tested have shown very low positive predictive validity and high rates of false positive findings. As a result, for the practicing clinician, these rating scales are primarily of value in learning to develop a thorough line of questioning about suicide. So what I've seen is that sometimes these scored instruments in use at a mental health center substitute for a more thorough risk assessment. If you're going to use suicide risk assessment instruments, I recommend that you do so just as one part of a structured risk assessment, and that you don't actually score the instrument to come up with some number or some specific descriptive term. For example, the instrument could contain a checklist of matters to consider while doing the assessment. Of course, if you use the instrument as a checklist, it's important to be sure that it's thorough and that it's appropriate for the specific patient being assessed. An instrument that assesses suicidal ideation, for instance, is just one part of a complete assessment. Well, unfortunately, many of the charts I see in litigation often contain very little documentation of the suicide assessment. Sometimes a provider only documents whether the patient expressed suicidal thoughts and/or had a plan. Of course, a good suicide risk assessment requires that the provider consider a good deal more than this. Even if you've done a thorough assessment, if you don't document it, it will be difficult, if not impossible, to remember, and the chart will create the impression that the assessment was brief and cursory. Well, that's it for now. Thanks for listening. I'm Ron Zimmett here on behalf of Negley Associates.